Today's presenter is Ms. Robin Haldiman. Did I get that right? All right. I didn't even go over that. She is the Chief Executive Officer at Child Health Investment Partnership of Roanoke Valley, and she is going to talk to us today about CHIP of Roanoke Valley and all the great services they offer. So thank you, everyone, for joining us, and I'm going to turn it over to Robin.
Okay, so as Alex said, I'm the CEO of CHIP. I have been with CHIP for about 22 years as heading up the organization. Child Health Investment Partnership is CHIP. It is not Child Health Insurance Program, which is often confused with what we do. Our mission is to change the lives of underserved children and their families through access to comprehensive health care and leading families to community resources. We were started here in Roanoke by a local pediatrician, Dr. Douglas Pierce. He's a very beloved man in this area. So we just celebrated our 30th anniversary last year. CHIP is a home visiting program. So we use nurses, registered nurses, and family case managers to conduct home visits monthly or more often as needed. And we serve pregnant moms and children at birth until they enter first grade. So we can be with a family for a very long time. And certainly if a mom has subsequent children, then we will be in that household for, even up to 15 years. So I wanted to talk a little bit about what our families look like. Because all of our families live in poverty, all of our children to be eligible for CHIP have to be eligible for Medicaid, which automatically puts them in an income category that is considered pretty much poverty. We do serve kids up to 185% of poverty, but those are typically families that are living on the edge and can definitely fall pretty far into poverty with an easy loss of a job or large medical bill. So all of our children have pretty high ACE scores. I'm sure many of you have heard of ACEs, but ACEs do stand for Adverse Childhood Experiences. So when you're seeing a child, many times what you don't know is that they have an incarcerated parent. Another ACE factor is a parent with mental illness or depression. That's hard on the child because they are not bonding with the child. Divorce, which oftentimes comes with a lot of verbal anxiety and shuffling of the children. Another ACE is drug and alcohol use in the home. And, of course, in Southwest Virginia and all over the country, we have quite a bit of substance abuse and opioid addiction. Neglect, and, oftentimes neglect goes along with a very depressed mom or a substance-abusing mom, and then abuse in the home. And that could be verbal abuse, it could be sexual abuse, it could be physical abuse. Our brains have this wonderful ability to, if they see a bear in the woods, they have this chemical reaction where they either have the fight or flight response. But if you can imagine living in a toxic environment where that response is going on in the child's brain all the time, it's going to affect their immune system, it's going to affect their brain development, their hormonal system, and even the way their DNA is read and transcribed. So this has some really dramatic health outcomes for our children. When you look at this next slide, you can see just kind of from the bottom up how that affects the foundation until they die. Historical trauma, so many of these parents have suffered trauma and lived in conditions that have been traumatic. The social conditions, which also are some of the social determinants of health, such as poor housing, living in food deserts, those kinds of things. And then their adverse childhood experiences, which are some of the trauma events that I just reviewed, and that in turn disrupts their neurodevelopment and their cognitive function, leading to some cognitive impairment, social and emotional impairment. Later on, these children tend to adapt risky health behaviors, which may include smoking or drinking or using substance, which of course leads to disease, disability and social problems, and early death. So my point in all this is that we definitely need to address these ACEs and these social determinants of health, which are different than ACEs, early on in life so that we can change the health outcomes for these kids as they grow older and become adults. So there's much literature that shows that if a child scores 4 or more on their ACE score, their chance of COPD and depression is 4.5 times higher than a child with a lower score. 7 or more on the ACEs, they have 3 times the lifetime risk of lung cancer, 3.5 times the risk of heart disease. And then this next slide just shows, 7 out of 10 of the leading causes of death from ACE exposure, and that goes all the way from suicide to heart disease, and how it is dramatically increased. So that's where leads me into talking about CHIP services and how we can help affect change and improve these health outcomes for children who are growing up in these kinds of circumstances. CHIP was started, as I said, in Virginia, in the Roanoke Valley, but we have expanded so that there are now 7 different sites across the Virginia area. If you're in an area that does not have a CHIP site, we'd be happy to talk to you about doing that. But this gives a little bit of data on the area which we include, which is Roanoke City, Roanoke County, Botetourt, Craig, and the city of Salem. For a child to be eligible for CHIP services, we'd like for them to be 5 or below, or really preferably for the mom to be pregnant and it be her first pregnancy. They need to live in the service area and, as I mentioned earlier, be insured by state or private health insurance. The private health insurance they'd still need to be eligible for Medicaid. And the gross family income could not exceed 185% of poverty, which is the limit for Child Health Insurance Program, or FAMOUS Plus. So CHIP uses registered nurses and case managers on their home visits, and it is a relationship-based program. It is that trust and the rapport that we develop with the family that helps to change the behaviors over the course of time. We're trying to improve both the parent-child bonding and that relationship, as well as improve the health outcomes for our children. So this next slide shows the number of our children that have medical home. Now this includes all of our kids, some who are newly enrolled that we haven't had a chance to hook up with a medical home yet. But, part of our whole literacy information giving is to teach families how to not use the emergency room for their primary care, but to use their pediatrician or family practice doctor. Our nurses are all certified as asthma educators. There are so many children in our Roanoke Valley that have asthma. So we're working very hard to help the mothers understand, or fathers, how to use those medications appropriately, to have an asthma action plan on file. We can help reduce environmental triggers in the home by giving out mattress covers and pillow covers and roach traps and humidifiers and those kinds of things. So really trying to save healthcare dollars and get those kids managed before they start school. And then, of course, I mentioned that we try to serve moms when they're prenatal. That's by far the best time to get the child so that we can affect the pregnancy outcome, certainly reduce NICU utilization, and get that child off to a healthy start. So we do transport moms to their prenatal appointments. We do prenatal health assessments on every home visit. We do flow sheets back and forth with the OBs so that everyone is communicating and on the same page. And we have some really good breastfeeding outcomes. About 75% of our moms are breastfeeding, and these are families in poverty. So that's a good statistic. And then, there are so many we have such an opportunity when we're in the home to impart a lot of different kinds of information. So we cover things like safe sleep, co-sleeping, shaken baby, nutrition, family planning, prenatal health, and oral health. I mentioned that we do transport. We transport the kids to their doctor's visits if the parent does not have any means of transportation, to dentist, to counseling, to WIC to get their food supplements, to developmental therapies and that sort of thing. And also touch very heavily on the oral health component because that's such an important part of overall health. And many times these children are growing up in families where the parents never had adequate oral health, so we try to start that very early by applying fluoride varnish at tooth bud eruption and educating the parents about the importance of oral health and getting the kids involved in taking care of their own oral health. And a couple years ago, we started a mental health counseling center because we realized that so many of the parents suffered trauma as children and had no way to process that trauma. Until this year, we didn't have Medicaid expansion in the state, so there was no payer source to pay for any sort of counseling for families. So we provide mental health counseling to adults for no charge, play therapy for the children if they should need it, and different ways to process trauma or violence that they've witnessed. I feel like this is such an important component of what we do and such an important way to affect the health outcomes in the future. I wanted folks to see that the majority of kids that we serve are patients of Carilion. So we have a huge collaborative with Carilion and really interact with those docs quite a bit and work very hard to make sure that the children are up to date on their visits and interacting with their pediatrician. I wanted to put this slide up here so that you could see the contact information. This is my contact information. If you have a child that's under the age of 5 or a pregnant mom that you'd like to refer to the program, just feel free to call that number with the extension. And I would love to entertain questions.
Okay, thank you very much, Robin. We have some questions already that we wanted to throw out for you. So I'm going to let Dr. Dunsmore go down the list here of what we've got, and then we'll open up the phone lines for questions. So I'm going to let you go ahead and take the first one.
Oh, so thank you very much, Robin. That's a great overview of a really wonderful resource in our community, and we truly appreciate it, Carilion Children's, the ability to have a collaboration with our community members who provide things that we can't. We don't often go into people's homes. We're not there in the place where you are, where we could affect all of the good outcomes that you are hoping to do and some that you've already accomplished over the years. In trying to understand how you do this good work, can you tell us how you're funded?
Okay. Yes, we have a pretty diverse funding base. Because we were replicated across the state, there's a CHIP of Virginia that has a lobbyist, and they do draw down. We get about $400,000 a year in state money. We do work with managed care companies to try to get some reimbursement for some of the case management services that we offer. And mostly we raise money from the community. So our fundraising goal is about $650,000 a year. So the vast majority is private money.
So you're really saying that from the state you get less than half of your operating budget. Is that correct? And rely on all of our community to help support this good work.
Absolutely.
All right. And then I want to understand a little bit more about how we might get more children into the program here at Carilion Children's. I think many of us as providers, maybe we don't know where they stand along the continuum for household income. So how would it be best for us to help identify a child and then speak with CHIP about whether they are an appropriate referral or not?
That's a great question. So probably in the chart you would know if they have Medicaid as an insurance or not. If they're Medicaid, they're automatically eligible for CHIP. And so the vast majority of those kids with Medicaid are going to have the risk factors that would make them a reasonable referral. But always, if you're not sure, just feel free to call that number and ask.
Then again, do they have to live within a certain geographic confine to get services? Because we do see children from out, in the entire valley. So what's the geographic constraint?
Okay, so we go all the way to Craig County, Botetourt County, all the way to Iron Gate, Roanoke City, Roanoke County, and the city of Salem. There is another CHIP site in the New River Valley, and there's another, the next closest one on the other end is Charlottesville.
All right. Thank you for those great answers, and now we'll open it up to see if anybody in the listening audience has a question for Robin.
I do have one question come in from the folks watching as a text question. Can you talk about what your current capacity is, how many staff you have? You mentioned having nurses that you use for case management. What's your current staff capacity? Are you able to take on more families? Is that something that you're looking for, or are you kind of at maximum capacity?
We are not at capacity, I'm happy to say. So we do have 5 community health nurses and 10 family case managers. There's 2 case managers to a nurse on each team, and the team caseload is typically around 84 cases. Our bilingual team is full, but we're hoping to hire a bilingual person in a month or so, which will expand our capacity to serve more bilingual clients. So we do have a bilingual nurse and 2 bilingual case managers as well. We've got quite a bit of room for enrollment, so love to take referrals.
Yeah, kind of following up on that, while I know Spanish is a language that we often need as a resource, we have been seeing a growing immigrant population that are non-Spanish speakers, but speak a variety of languages. How do you handle that at CHIP?
Well, that has been a challenge over the years because, because it's a monthly home visits and it's such intensive intervention, it's more than just a 15-minute visit. So we have been working with Synergy Language Services. They're doing quite a lot for us, but typically we have to have someone in the home that can speak at least some broken English. That really helps us.
Okay, and then we also have the question about the additional collaboratives that CHIP is involved in the region, maybe in Roanoke Valley or beyond. So can you speak just a minute to that?
So we've been very fortunate to lead an early childhood collaborative, and because we can't do it all, and so if we join hands with a lot of the other nonprofits in the area, our reach can go much further. We are now able to partner with Leap Mobile Market to give free vouchers to our families that need fresh produce. We give bags of produce through Southwest Virginia Food Bank. We can purchase slots for child care for our moms wanting to go back to the workforce through Greenvale. We can purchase after-school slots with West End Center, Community Outreach Program, which is now Kids Soar, a lot of other organizations. So I just feel so honored to be part of this big collaborative and to be able to really extend our reach. We're currently doing financial classes and budgeting classes for our, through Bank On for many of our families as well. So it's a great question.
Fantastic. Okay, last two, and then we'll open it up as we draw to a close here. From your standpoint, having been involved in this for the last 20 years, what do you see as the community's biggest need when it comes to child health? And then a follow-up to that, what do your staff see as the biggest need that they don't currently have? What's their gap to provide that resource to meet the need of our community? So kind of two questions on that.
I think that pediatricians and family practice docs and folks in the healthcare community have a real opportunity by kind of zoning in on these adverse childhood experiences and looking at some of the social determinants of health for these children that are growing up to really make a difference early on while that brain is developing. To me, that need just for broader education and understanding on how to intervene and refer to really shore up these kids so that the health outcomes in the future are not going to be so expensive and out of control. From our perspective, of course, from the CHIP perspective, the need is always to continue to find funding sources because they come and go all the time to better meet the needs, because there are 6,000 children eligible just in the localities that we serve for CHIP services. So we're only reaching about 800 of those 6,000 on an annual basis. I'd like to serve every last one of them, but, it's a resource issue on many levels.
Well, thank you for that information. We've got about 3 or 4 minutes left, so I'm going to unmute the phones here. If you are listening and you do not want to ask a question or make a comment, please put your phone on mute now.
The conference is now in talk mode.
Okay, does anyone on the line have a question for Robin or want to make a comment? I already had several come through the text version here. Everyone's always quiet and shy on the phone during these. That's okay. That means you've covered everything and they're good to go. Okay. To wrap things up here, is there anything you want to say as kind of a wrap up? You have the audience here. We have our recorded audience. You've kind of talked about how people can reach you. Is this the best number to get more information? You've talked about your website. Anything in closing that you want to say to the audience?
I don't think so. The website does have a referral tab on it, so if there is a child that you feel like could really benefit from services, feel free to send the referral through, and we will contact that family. I'll just close by saying that, there is a lot of evidence now that's being presented that parent-child relationship can really mitigate a lot of these adverse experiences early on. So it's important that we keep working at that. And I'm proud to be able to do that.
Excellent. All right, I have one final question that we will close out with that has come in. Does this require a medical referral for services? Can parents self-refer or family members self-refer?
Yes, about 42% of our referrals are self-referrals. In fact, they're folks that have friends or neighbors that have a CHIP nurse that comes and they want her for their child. So absolutely, self-referrals are welcome.
Fantastic. So thank you very much for this information. Obviously, this has been, 30 minutes. It's a bite-sized segment. We could talk for hours and hours about this topic, so we definitely want to invite you to come back and have more time to talk with our group. But thank you for making the time today to come in. Thank you, Dr. Dunsmore.
And, Robin, thank you for heading up such a wonderful resource for the youngest and most vulnerable of our community. Thank you, Kim.
Okay, so we went through our questions here. For all of you listening, either live or as a recording, remember you can claim 0.5 hours of Category 1 AMA PRA credit. If you're listening live, go to your calendar appointment that you received your login information on and click on the CME survey there. If you're listening to this as a recording on our YouTube channel, go to the notes section and click on the CME survey there. You can find all of your CME that you have done with Carilion by going to carillionclinic.org/CME and clicking on the CME tracker site. It's a centralized spot that everything that you do through Carilion at any educational event from any department or service line gets sent to this one hub. So it makes it really easy to, at the end of the year, find out how much CME credit you've had. Again, if you want to find us on YouTube, search Carilion Children's CME in the search box, and you can see all of our recordings. You can also go to or email us any topics or suggestions for future presentations by emailing us at outreach@carillionclinic.org. With that, we are going to end right on time. We appreciate your time this afternoon. Enjoy spring break. Thanks.